Hello and good evening, one and all. I, Dr. Savri Sawant, on behalf of Team Voice of Healthcare, welcome you all to our second episode of Male Osteoporosis, speaking up on the silent diseases, which is organized by Voice of Healthcare and powered by Zydus. I welcome you all. So, the topic of this panel discussion today is understanding the clinical signs, symptoms, and risk factors of male osteoporosis. As we know, male osteoporosis is just not a female disease, it also affects men. We have some very eminent panelists here with us today. We have Professor Dr. Dilip Shah, who is the Honorary Orthopedic Surgeon of Saifee Hospital and Nanavati Hospital and Saint Elizabeth and Cumballa Hills Hospital, Mumbai. Welcome, sir. We also have Dr. Syed Imran, who is the Consultant of Orthopedic and Joint Replacement Surgery with Manipal Hospital, Millers Road, Bangalore. Welcome, sir.
Good evening.
Next, I welcome Dr. Vispi Jokhi, who is the CEO and orthopedic surgeon of Masina Hospital Trust, Mumbai. Welcome, sir. We also have Dr. Yogesh Pithwa, who is the senior consultant spine surgeon at Sattvik Spine and Scoliosis Center, Bengaluru. He would be joining us shortly. We also have Dr. Arjun Dhawale, who is the consultant of orthopedics at Sir H.N. Reliance Foundation Hospital and Research Center, Mumbai. He would also be there with us shortly. We also have for this session Dr. Swapnil Dambre, who is the consultant of orthopedic and arthroscopy surgeon at 𝐒𝐄𝐃 Multi-Speciality Hospital, Thane, Mumbai. He would also be there with us. So this session would be led by Dr. Vispi Jokhi. So now I hand it over to you, sir. Sir, you are on mute.
Good evening, everybody. We look forward to a very fruitful session today. We will be having a few rounds of questions. We'll be directing the questions to the surgeons, and we request each one to keep their answers brief and to the point so that we can cover up all the topics. So the first question relates to the risk factors and prevention of osteoporosis, and it is directed to Dr. Syed. So the question is, what are the biggest risk factors for male osteoporosis, and how can male osteoporosis be prevented?
Yeah, good evening. Yeah, good evening. I'm Dr. Imran. I'm from Bangalore. My question, what sir asked me was, what are the risk factors and how do we prevent it? Before I come to it, I would like to define osteoporosis as a silent disease. It is a disease which manifests itself only after you have had a fracture. Most of the awareness for osteoporosis has always been directed towards women. It is not that men don't suffer from it. Men do suffer from it. And the whole point of doing this talk is to create the existence of osteoporosis in men and the impact it is having. And if you look at the worldwide statistics, it is seen that almost 1/3 of the hip fractures, which are the most common manifestation of osteoporosis, are present in men above 70 years. So hip fractures occupy about 30% of the fractures because of osteoporosis. And coming to what are the risk factors that are there for osteoporosis is, the first most important thing is aging. As a person starts to age, the bone starts to lose some calcium. So this is a disease of the old age. Not that the younger people also do not get it, the younger people do get it, but in case they are suffering from other diseases. So most commonly it is seen in men above 70 years, almost a decade later than you would see in women. And then the other common factors, risk factors, are having low vitamin D, poor calcium intake, smoking, alcohol intake, um, uh, excessive intake of coffee, or in case they have hypogonadism, or treatment for prostatic cancer or anything. Now coming to, what are the types of osteoporosis? Basically, there are two types of osteoporosis. One is senile. Senile is basically seen because of aging. As one age increases, there is osteoporosis. This is the osteoporosis which is also called senile, which is because of aging. The second thing is idiopathic, wherein the cause is really not known, and then there are secondary causes of osteoporosis. Most commonly, it is seen in cases of ankylosing spondylitis, rheumatoid arthritis. These are the things that would lead to osteoporosis. Now, coming to what are the ways by which we can prevent it. The first most important thing is any person who's taking in a lot of salty foods being in terms of be it this chips, be it this savories, a lot of salt, because it is seen that increased salt intake reduces your calcium intake. And then, the most common, the new thing, because of the COVID, everybody's gotten addicted to the social OTT platforms like Netflix and other things. So too much of binge watching, which means to say you're spending too much of time in front of in front of the monitor, reduces your exercise time and your exercise time. So this leads to osteoporosis again. And then, since you're binge watching, you're not exposed to adequate sunlight, which leads to low vitamin D, again leads to osteoporosis. Excessive alcohol intake, excessive intake of uh, flavored sodas, smoking, and this is one of the, osteoporosis is one of the disease whereas being underweight makes you more prone to have osteoporosis. So these are the risk factors by which you can have osteoporosis. Now, how do we prevent it? Prevent it is by exercising adequately, reducing your caffeine intake, alcohol intake, and smoking intake. These are the ways to prevent osteoporosis. So with this, I sum up some of the introduction on osteoporosis. Now over to you, sir.
The total overview on osteoporosis. Now, I think Dr. Dilip Shah, the question to you was, what are the clinical signs and symptoms of male osteoporosis at different ages, and what are the things that the people should be made aware of? How do they find out whether they really have osteoporosis or not? What are the red flags? So basically, Dr. Dilip Shah, please take over.
I thank first and foremost for inviting me, and I thank Dr. Vispi Jokhi to ask me this pertinent question. And has been already told by my two previous speakers that while the disease is more common in women, men are also at risk of osteoporosis. So you cannot say that men are immune. The misconception that osteoporosis is a woman disease likely stems from the fact that women are at risk at much earlier age. Like it has been told that by the age of 50, when they are perimenopausal, osteoporosis may set in, but typically beginning in their 50s, as I said, and right around the menopause. Yet men over the age of 65 to 70 are prone to get osteoporosis. Now, when you see the symptoms, it has been said that it is a silent disease. But when you try to examine them, that over the spine, there may be areas, especially in dorsal or dorsal-lumbar junction, if there has been a compression fracture or it has been wedging of a vertebra. Besides, there is loss of height. I am 6 feet 1 inches, and if my height reduces to 6 inches or 5'11", then it's because of the crookedness. We call it as kyphosis. If you see in lateral position, you start stooping down, the stooped posture, and if they get a fracture, then it is confirmatory. It begins from maybe spine, hips, distal lower end of radius bones, that these fractures are very common. So, as I told you, the signs are tenderness over spine. Now, to confirm this, we need to do a lot of investigations like calcium, phosphorus, alkaline phosphatase, which may give us
Dr.
low
Shah, we'll leave
calcium.
it to the other speaker to speak for that, the tests and all that. But what I want to ask you is, would you sort of therefore say that any male patient
No, but
coming with
then
her,
science, let me complete it. Maybe there
yeah,
is a repetition. DEXA T score less than minus 2.5 or less, and low calcium and vitamin D3 levels. And the causes, it will be a repetition for everybody, because if you ask a question pertaining to osteoporosis, we are talking about it. So low intake of calcium, low intake of vitamin D, potassium, or even proteins, and being sedentary, or overuse of alcohol, cigarette smoking, long-term use of medications like corticosteroids, and if you take some drugs like prednisolone for asthma or arthritis, some anti-epileptic medicines, anti-seizure medicines, also, and overuse of aluminum containing antacids. So eating disorders also, where you don't eat properly and you cannot digest well, or low levels of estrogen in females and low level of testosterones in males are the causes, and we should try to prevent, investigate, and treat them accordingly. Thank you very much for the time given to me, and you
yeah.
can take over.
So I think thank you for your detailed discussion on the signs and symptoms. We have Dr. Swapnil has joined us. Sorry, we have finished the first two questions, Dr. Swapnil. The next question is relating to the investigations. So the question that is asked to you is, what are the different diagnostic tests which we can specifically use for male osteoporosis?
To begin with, to primarily diagnose osteoporosis, the gold standard is DEXA scan. A DEXA scan which shows a standard deviation of minus 2.5 or lower will generally confirm for us osteoporosis in males. There are certain controversies regarding that because that has been extrapolated from females. But generally, it's accepted consensus that lower than minus 2.5 tends to be osteoporosis, and between minus 1.5 to minus 2.5 is osteopenia. So that will confirm for us what is
Are there any
osteoporosis.
blood tests also to be done?
Exactly. So coming to that, there are two kinds of blood tests. We can look at blood tests which are relating to bone turnover and also causes of osteoporosis. So investigation for causes of osteoporosis and confirmation of osteoporosis. So in confirmation of osteoporosis, bone turnover markers are there, including serum alkaline phosphatase and a couple of other markers. And other aspect of it is diagnosis of the underlying causes of osteoporosis, where there are various series of blood tests which include looking at thyroid hormone, parathyroid hormone, serum cortisol level, androgen levels, as well as looking at serum homocysteine, because hyperhomocysteine also tends to give rise to osteoporosis in males. So on the whole, blood tests are generally designed, unless you are in research setting, blood tests are generally designed for diagnosing the underlying causes of secondary osteoporosis as compared to primary osteoporosis, which is generally lack of underlying risk factors and senile osteoporosis.
Just one more addition. What is there any role for bone-specific alkaline phosphatase as against a general alkaline phosphatase test?
Yes, indeed, it's not a very crucial role, as I said, because as clinicians in the research setting there are other markers as well. But in a clinical setting, I would say on the whole, DEXA scan will give you the confirmatory diagnosis. But yes, in research settings where you're trying to look at, because there is research still ongoing as to whether the DEXA scan the data that has been extrapolated from females to males is something that we need to is extrapolatable, and that research regarding that is going on, but not in a clinical setting.
Okay, thank you. The next question is to Dr. Yogesh Pithwa. I don't know, he was here just now. I can't see him on the screen. Is he there, or I don't think he is there? If he is there, then the question, if he cannot answer, someone else can answer. What is the difference between DEXA versus bone density assessment by ultrasound methods? Anybody would like to take that question up? Dr. Dilip Shah would take it up. Please unmute
Yeah.
yourself and speak.
So what happens is, like if there is, say, floods, and minister goes in a helicopter and tries to see how bad is the flood. This is how we do a scanning, whereby from all the people whom we see, we can find out it is done by ultrasound, is done at the heel level, or maybe done at the finger level. So this gives you a rough idea. So out of that, if you find out those who are going into the level of minus 2.5 or something worse than that, then they need to be studied. So DEXA is a very confirmatory test of osteoporosis, whereby we have the standard minus 2.5 or worse is osteoporosis, as it has been said by Dr. Imran and others also. That's
Okay, Dr.
Swapnil
Yogesh
also.
is here. Dilip Shah, sir. Yogesh is here, so I would like him to take. Please go finish your answer, but I would ask him also to add on to this
You
question.
could have said that later on. No, you interrupted in my talk, really. So when you do DEXA scan, you get definite answer, and minus 2.5 to minus 1, you can say it could be osteopenia. Some people take it up to minus 1.5, and minus 1 to 0 or plus is normalcy. So whenever we do a kind of screening, this is basically screening by ultrasound, and you can have some camps also whereby people become aware of this, and you can kind of find out who are the people who will need definite study by DEXA scan. Thank you very much.
Dr. Yogesh, are you there? Dr. Yogesh, just unmute yourself and speak, please. Dr. Yogesh Pithwa, I think he must be having not a very proper connection. Anyway, then we can go on to the next question. That's to Dr. Arjun Dhawale. Arjun, I always have wondered about exercises in osteoporosis.
Yes,
We
sir.
talk about
I'm there. I
weightlifting,
apologize.
stretching.
I'm having a lot of connectivity issue.
Yogesh?
Yeah, I'm there. I'm very much there.
So, Yogesh, please go ahead. Then, I doubt to tell Dr. Dilip Shah to
Yeah,
answer
I'm
a
very much
question.
there. Am I audible?
Yeah, you're audible. So, please go ahead and tell us the difference between DEXA scan versus ultrasound scans for osteoporosis, and whether what is more effective and better. Hello, please go ahead. Hello. I think we are losing him again. So then I think Arjun, please, we are losing him again after Asavari. So I'm going
Yes,
ahead
sir.
with the
I
next
guess
question.
there is some severe connectivity issue with Dr. Yogesh. So I would request you to please take his questions to someone else.
Okay, Arjun, we already finished that question. Arjun, see, I've always wondered what are the exercises we recommend to a patient of osteoporosis. We always talk of weightlifting versus stretching. So I would like some clarity on that, whether there's any difference between males and females as far as exercise is concerned.
So thank you very much, sir, for the question. So in osteoporosis, I think exercise is the key, and any form of exercise is actually good. So even, walking, and it has to be age appropriate too, so basically if we divide it off, there is stretching, there is strengthening, there is weight, sort of balance exercises and flexibility exercises. Now, a combination of all is actually what is necessary. So obviously something like walking, aerobic exercises, jumping, etc., skipping is good, for the lower limbs. However, gentle weights for the is also important for the upper body, and because you want to load the loading of the bones and the spine, and is sort of important. Of course, flexibility and stretching is also important, and it's like how we're looking at the DEXA, right? We're looking at the DEXA by using the average of the hip, the forearm, and the spine. So effectively, we want to strengthen all the areas, the axial and the appendicular skeleton. And as you grow older, it is definitely recommended that some weight bearing is done. So some light weights is especially good to build up the bone density. But I believe that everything needs to be sort of calibrated as per the patient's requirement, the patient's functional ability, and if there are any sort of comorbidities, then these need to be taken account. So recommending a 75-year-old patient who's having a lot of problems to go skipping is probably not appropriate. So it needs to be all balanced.
Yeah, so basically you don't seem to believe that one is better than the other. It's exercise in general, and when the oft-repeated advice that we used to traditionally give the mother to lift your child so that you can take care of osteoporosis is not really valid. Is that what you're saying?
Yes.
Yeah. Okay. So the next question is the round 2 that we are coming into in this debate, and it relates to andropause versus menopause. And what is the difference between andropause and menopause as far as the osteoporosis is concerned in males and females? Are they the same or are they different? This question is directed to Professor Dilip Shah.
Again, please. Vispi.
Yes.
Yeah, can you reiterate your question, please?
So the question is, what is andropause and how does it affect the onset and progression of male osteoporosis, and compare that with menopause in females?
Right. You see, as the age advances, the hormones, they start receding, and hormones are the main thing which maintain your general health, and essentially they are very important for your bone quality also. So like ladies, they have reduction in their estrogen level, and they around perimenopausal age, and then the ovaries, they lose their function, so the estrogen level, they dip down very quickly and they enter into menopause. But men have been blessed that we don't have to bear the labor pain also. And as the age advances till the age of 65, the androgens, they work wonderfully well, but then the androgens also, they start going down, and then we have the male hormone which goes down, and that causes andropause or male menopause. So along with the bones, actually we should take into account even the muscles also. So we get sarcopenia. Muscles are known as sarco. So sarcopenia also. So it becomes a vicious cycle that the muscles also, they lose their power. So in turn, the bones also, they become weak. So this is how the male andropause sets in at the age of around 65 to 70, and menopause occurs at the age of 50 in females. So similarly, it goes glove in hand, osteoporosis. So ladies, they get menopause and they get osteoporosis at the age of 50, and the male, when the andropause sets in, they have the bone quality, muscle quality, everything deteriorating by the age of 70. Thank you very much for your question, and if there is anything else anybody wants to add, can go ahead.
Yeah, anybody wants to add in the group? Dr. Syed, anybody? Okay. Since nobody wants to go ahead with, we'll go to the next question. This is addressed to Dr. Swapnil. It relates to the treatment protocols for male osteoporosis, particularly in India. So would you like to elaborate on that?
Okay. Yeah, thank you for the question. I basically try to differentiate between primary and secondary osteoporosis. If you have somebody who has secondary osteoporosis, it is important to try and address firstly all the underlying causes of the secondary osteoporosis, whatever they may be, ranging from all kinds of endocrine disorders to hypogonadism to hyperhomocystinemia, type 1 kind of diabetes, if it's controlled or not. So that is one aspect so as to stop the osteoporosis from getting worse. So it has to be addressed. Now, essentially, once you address the background disorders, then you have to look at the osteoporosis per se as to how bad it is. Assuming that the patient has minus 2.5 or worse, that also requires treatment. My protocol generally is to use two tools. One is DEXA scan, and another is something that the Sheffield University has come up with, known as FRAX assessment. And if the FRAX assessment score gives me a hip fracture score of more than 3% or a general big osteoporotic fracture of more than 30%, and if I combine that with with a DEXA scan, which is less than 2.5, which is obviously osteoporosis, then I will give them both zoledronic acid as well as giving them teriparatide pulse therapy. Both will be combined. On the whole, if the FRAX assessment is okay, but the DEXA scan confirms osteoporosis, I'll just give them pulse therapy. Maybe at a later stage, to lock it in, I may follow it up with zoledronic acid. I don't tend to prefer alendronic acid unless it is in osteopenia, because it has been shown in certain studies that most of the oral bisphosphonates will interfere with some of the anabolic activity of teriparatide, which is a worry if you have somebody who is treating osteoporosis. So somebody with osteopenia, I will stick to simple things like calcium, alendronic, and vitamin D. Whereas with somebody with severe osteoporosis, I will tend to go with either teriparatide if the FRAX score is okay, or teriparatide with zoledronic acid if the FRAX score is bad as well as the DEXA is bad. If anybody would like to ask anything or add anything more than that.
Swapnil, the question was actually related to the different protocols for treatment of osteoporosis. So would you all the time go for zoledronic acid straight away and the teriparatide, but you won't try alendronics at all?
When you have a patient with osteoporosis, I don't tend to prefer alendronic, because the simple reason is that if there is a potential possibility that I may need teriparatide, it is something that will be interfering with other oral bisphosphonates. So that is one aspect. The second aspect, as a clinician, I worry about compliance in these patients. In the sense, will they take that therapy for that long period of time? Whereas with zoledronic, you take the compliance out of the picture, and then there are nowadays newer recommendations which are showing that zoledronic you can give at a 1.5 year interval as well, not necessarily 1 year. So it becomes very convenient for the patient. Compliance gets taken out of the picture, and you don't worry about the interference with anabolic effects of teriparatide.
So the other question, which actually Yogesh Pitle is supposed to answer, but his connectivity is not good. So what I ask the panel, anybody wants to volunteer to take up this question, what is the difference in treatment of male osteoporosis versus female osteoporosis? Dr. Syed, would you like to take up this question?
Yes, sir. I think in female osteoporosis, generally, especially in younger females who have had that ovarian history, the uterus and the ovaries removed, for them a hormone replacement therapy is given. I don't think this plays a role in terms of for the male patients. I think beyond that, I think it is more or less the same. No, I can't hear you, sir.
Jokhi, you are muted. Treatment of male and female osteoporosis.
No,
except because hormone replacement is hardly ever done now. Yeah. So by and large, the treatment is same. Would you say that?
Yes, sir. I think by and large, the treatment is the same.
Acha. The next question is addressed to Dr. Arjun Dhawale. Arjun, everybody talks about zoledronic acid and the amount of zoledronic acid which is prescribed. Can you tell us a little more about your experience in using zoledronic acid in patients of osteoporosis in males in your practice?
Okay, so I usually use bisphosphonates as my first option for treatment. And I would actually sort of use the oral bisphosphonates before I recommend the IV bisphosphonates, which is alendronate over zoledronic acid. However, there are particular situations when zoledronic acid is the first choice. So it is in situations where, say, the patient is inpatient. He's osteoporotic or she's osteoporotic, and is going to require. It's clearly documented. Then you can go ahead with the IV zoledronic acid. However, there are a couple of things. It is also the drug of choice in cancer patients who have hypercalcemia. It is also the drug of choice for Paget's disease patients. One has to keep in mind that you should look at the serum calcium levels, because if there is a hypocalcemia, zoledronic acid should not be used, because it may sort of accentuate the hypocalcemia. The other situation is in renal failure. So if it's a CKD patient, or end-stage renal disease patient, then the dose needs to be adjusted. It needs to be adjusted to the renal dose. So usually that's like it's like a 2 mg per 100 versus a 5 mg per 100, which is what we are usually sort of giving. And of course, one needs to find out if there is any dental caries or any sort of dental treatment which is planned in the near future, because again, that is one of the issues. Osteonecrosis of the jaw can occur if there is any dental treatment which is planned around the zoledronic acid treatment. Mild fevers can happen, but that is sort of expected and patients can be counseled. But overall, it's a great drug because it's the cost is reasonable. It's a single shot administration, given over 2 hours slowly, and the compliance, is sort of good because it just needs to be given annually, and usually it's quite an effective drug to use both males and females.
So what you are trying to say, and I would like to again ask you to elaborate, that it's not just the mere compliance which is the reason why you use zoledronic acid. There are specific indications, and there are specific side effects and problems. And I don't think we should just mix up alendronate oral versus zoledronic as the same thing. Is
Correct.
that what you are trying to say? It's a
That's
different
right.
thing. Both
Absolutely.
the things are different.
And any patient who's not going to be able to tolerate the alendronate therapy, has GI side effects, etc., then this is a reasonable drug because you're kind of bypassing that, that side effect, of the oral bisphosphonates with the IV.
So, in your view, would alendronate be the gold standard by and large, and we use the other therapies as and when required?
Yes, I mean broadly that is sort of the way at least I practice,
Okay.
and it's unless the patient is not having the ability to sort of
And I think
having adverse
obviously we need to treat the secondary cause. I suppose if there is a secondary cause, there is no dispute. We need to
Absolutely.
treat the secondary cause, and that should be the treatment for the disease itself.
Right, and having
Anybody
the
wants to add something on this?
investigations, having
in
the
the panel?
appropriate investigations is very important before initiating treatments, I feel.
Yes. Again, please come again.
Having
last
all the
sentence.
appropriate lab tests done, earlier
Yes.
is critical. Because like for example, if you're thinking of even teriparatide, if your PTH level is elevated to start with, it's not the right treatment to give.
Correct.
Or for that matter, like I told you about the serum creat or the eGFR, what we look at, the eGFR.
Yes.
If there is a reduced eGFR, then probably you should not be looking at giving the full dose zoledronic acid. Then you need to give the renal adjusted dose. So I think these are some of the subtle things which need to be looked at.
So the next question relates to recent advances in treatment of osteoporosis, and I think Dr. Syed Imran has been chosen to give this answer. So
Yes.
can you tell us about any latest newer therapies and newer advances in treatment of osteoporosis?
So the newer advances in for osteoporosis, I think till some time back was teriparatide, but again, that I would not call that gold standard. As Dr. Arjun told, I think the bisphosphonates is still the gold standard for osteoporosis management. And teriparatide is basically an analog of parathyroid hormone, which is given. And like pointed out by Dr. Arjun, it cannot be given in patients who have renal failure or who have elevated parathyroid, which is basically a cause of secondary hyperparathyroidism. For these subset of patients, there was a new Rankel ligand inhibitor called denosumab, which had come in. This is again has limited role. And when I was looking up at the research, I mean, I have not used anything beyond denosumab. I was looking at the research to see what should be my answer for this. I found 2 new molecules, which personally I have not used. One is something known as abaloparatide, which is a congener of parathyroid hormone, which works similarly like teriparatide. And then the second molecule I found out was something called romosozumab. Apparently, this is an injection which is taken every month in the doctor's clinic for about a year. This is also like a congener of denosumab. Again, coming to the newer things, with bisphosphonates, you cannot give it they're not the ultimate this one, and they cannot be given for beyond 5 years. The data says between 3 to 5 years. Beyond that, you have to give a drug holiday of at least 1 year. The reason for giving a drug holiday is they can lead to atypical femur fractures and osteonecrosis of the jaw. So there should be a drug holiday. So I mean, some of the patients did ask me in between, doctor, does my fracture risk increase during the period of my drug holiday? But actually, the bisphosphonates are longer acting. So even once you stop the drug, their action would continue for at least for a much longer time, even after stopping the drug.
By much longer time, you mean a few months or few years?
Yeah. Maybe a few months. I am not sure of the timeline.
Okay. Hey, the question, I since it's going on, I mean, we have time. We are well on time, and one of the speakers is not there. I would like some of you all to, elaborate a bit on how do you institute the treatment of osteoporosis by alendronate, and do you need to give a break in between? And what are the intervals in which you sort of prescribe the drug and then again give a break or again continue, and for how long you should continue the treatment? Anybody wants to volunteer to take this question? Please raise your hand. Anybody wants to? Dr. Dilip Shah. Okay, go ahead.
Thanks for passing on the question to me. Bisphosphonates have been basically the treatment which we started with. It could be once in a day, it could be once in a week, it could be once in a month, orally. But a very important point which is to be hammered in the minds of the patients is it should be taken on empty stomach. For next half an hour to 1 hour, one should not eat, drink, or sleep. And it should be swallowed very quickly so that the medicine should be made very smooth. Otherwise, lower third of the food pipe, known as esophagus, may have very little increased chance of having cancer. Now, patients found it difficult to have it once in a day, so became once in a week, and then became once in a month. But then the intravenous zoledronic acid we actually inherited from our oncology cancer doctors who were using 4 milligrams, and they were giving more frequently than once in a year. They were giving almost once in 6 months or even once in 3 months. So that became 5 milligrams for osteoporosis treatment or osteopenia treatment rather, and that is to be given once in a year. From there, we migrated to bone forming kind of agents. So, in short, if we were to actually think about this bisphosphonates, we have two types of cells in our bones. One is osteoclast, and other one is osteoblast. So, if you give any kind of ibendronic acid or zoledronic acid or anything like that, which is known as bisphosphonate, then we are retarding the activity of osteoclast. So there are many people who thought that by trying to protect a fort by old soldiers, you are not going to protect your bones. The study started with Aclasta, which was of Pfizer, and they decided that we will give you an insurance the moment you have been infused with zoledronic acid. If you get a fracture, we'll treat you freely. But that is not the truth. Once you take zoledronic acid intravenous, that doesn't protect you. You can take it maximally up to 5 years, and there are some atypical fractures of femur bone which happen if you try to take it continuously. But the point is, once you start this treatment, DEXA scan is not going to change for practically 2 years. So there are some blood investigations, which is known as C-telopeptide. When you give the agents which reduce the osteoclastic activity, or they reduce the activity with which osteoclasts are working, and if they show change to the improvement side, then you can continue for 5 years. But then you have to stop giving zoledronic acid, and by then patient, if their DEXA scan, if it is not deteriorated, that is also a positive sign. There are many patients who feel that after having taken this treatment, your DEXA scans should improve, which is not reality. Even if it does not deteriorate, that means you have gained something. So this is how we treat osteopenia. But when we talk of osteoporosis, there was one question which flashed. So if you want to take up, Sir Vispi Jokhi, you can take up that question. You are muted, sir.
So so basically, there is a little bit of controversy on what is the line of treatment. One is, what my question was basically, do you need to give a break when you are giving treatment by oral analgesics? Do you need to give a break in between, and for how long can you continue oral analgesics? Anybody wants to take this question up?
Yeah, let somebody answer. Otherwise, because that question, patients have less compliance for oral if they are taking once in a day. You can safely
That's
continue.
Okay. I'm not talking about once in a day. Once the patient is compliant, do we after
give it up
to
to
1.5
years.
years give a break?
Give it up to 5 years. You can give it
up to 5 years. You can continuously take it.
Yes, but then make sure about two things. As I said, C-telopeptide should improve. Otherwise, it's pointless continuing with that.
Okay, fine.
You should have a baseline C-telopeptide, and after 3 months, you see, after having given first shot, after 3 months, you see what is C-telopeptide, and maybe after 4 years, you can give C-telopeptide, and if it's giving improvement, you can continue up to 5 years. When you give orally,
Dr.
also
Syed wants to say something.
No, I wanted to say that I do it for 3 years and give a drug holiday for 1 year. There was no blood test done in between to see, like how Sir told, between the N and the C telopeptide. Give it for 3 years. If the patient is compliant, give a 1 year break, and then restart it. But unfortunately, the problem is the patients don't see benefit, because the benefits is only in the blood tests and the bone thing. They don't. Perceptionally, they don't feel any change.
Okay, so now anybody else wants to speak on treatment in any other form? Arjun, you want to add something?
Yeah, so basically, there is the last group of drugs, which is the denosumab. That drug is sort of to be reserved for patients who have renal failure, or patients who have any sort of form of malignancy, who are not able to tolerate or take zoledronic acid for any reason, but the issue with the denosumab is it's like a subcutaneous injection given 6 monthly. But the one sort of drawback is that if you start it, you can't stop it. And I think that's something that needs to be kind of remembered, because you will have rebound osteoporosis if you stop it. So that is sort of that group. And of course, the teriparatide is the group of drugs which is a good drug post surgery. So if your patient has a fracture and you've done a fusion, or you're planning to give it in osteoporotic female patients after surgery, spine fusions, etc., that is a good drug, because that also helps with the bony fusion along with improving the bone density. But of course, it has to be remembered that it is to be given for only a duration of up to 18 months to 2 years, and it is contraindicated in patients who have a history of malignancy.
Vispi, you are muted. Vispi, you are muted.
So now I come to the last question, which is to be answered by all the panelists. As male osteoporosis, I'll read out the question. As male osteoporosis is not simply a disease related to aging, and there are many conditions exaggerating bone loss from early years of life. So on this Father's Day, what is the take-home message that you would like to give all the males watching this episode for maintaining bone health from early on? So let's start with Dr. Syed, and I think Dr. Dilip Shah will give you the last word.
Sir, my take-home messages. The first one is the the peak bone mass is attained at the age of 35. So, and then after the age of 35, the peak bone mass keeps decreasing. So keep yourself active by doing weight bearing exercises. The stronger your bone, the lesser the chance of osteoporosis. Maintain an ideal body weight. Reduce the risk factors, and maybe get diagnosed. I think if I were to put it in a guideline, when do you do a DEXA scan? Maybe any male patient who's had a fragility fracture at less than 50 needs a bone scan, or anyone above the age of 65 should do a DEXA scan, get yourself diagnosed first, and then treated appropriately. This would be my take-home message for everyone.
So that means this message can work only for under 35, not the whole.
No. Beyond 35, less than 50 with a fragility fracture needs a DEXA scan, or beyond 65, all males should get a DEXA scan.
Okay, Dr. Swapnil, can you elaborate on the same question?
Okay, for all the fathers, the first thing I would like to say is make sure you get a lot of exercise and you take your vitamin D. Make sure your calcium intake either through food or through supplementation is good. So vitamin D is very important because vitamin D deficiency is rampant nowadays. Pretty much everybody is vitamin D deficient. So make sure you take your supplements, make sure you do your exercises on time. And the other thing I would say is, rather than get into nitty-gritty of things, I would say seek help early. Just because you're male doesn't mean you won't get osteoporosis. Just because you're male, if you're getting bone pains, seek help early. We have a lot of professionals who can help you get to the right treatment, and treat it early. You will be able to prevent osteoporosis rather than getting it and then getting it treated. So exercise, vitamin D, lots of calcium, preferably in diet rather than in tablets, and seek help early if you're getting bone pains.
Okay. So the next speaker, Arjun, what is your take on this?
Since it's Father's Day, it's for Father's Day, so I'll suggest, like, simple thing is you play with your children outdoors. Try to spend more time playing with your children outdoors, and that itself is a great form of exercise. They'll keep you on your toes, and they're obviously fitter than you, so you'll kind of have to chase them down or play something with them, which is it's a great activity to bond also, and it's also going to help you to keep fit. And try to do something with them. That's a nice way to bond with children also. Smoke less, or stop smoking if you are a smoker, because that's actually going to accentuate and worsen your osteoporosis. And drink less. I mean, that's again another thing which will add to your osteoporosis problems. And so have a healthy lifestyle. Sort of eat correctly and have a balance. And of course, if you have any medical issues or you do sort of think that there is something, then obviously consult their professional so that they can put you and guide you correctly. There are rare instances where younger patients can have osteoporosis, and even young males sometimes if there are any endocrine issues, etc. And they need to be looked at. But overall, I would not sort of worry too much and just stay active. Thank you.
Arjun, can you elaborate on what is the relation of smoking with osteoporosis? Because many people don't know that.
So apart from all the other disadvantages of smoking, in terms of cardiac risk, risk of cancers, etc., it is a well-known fact that smoking does decrease the bone density. So it is one of these environmental factors which can be controlled by you. So if you quit smoking, you are actually improving your metabolic bone health. So this is a documented sort of fact. Thank you.
Okay, last, Dr. Dilip Shah, can you just answer this question?
Yeah, most of the people have already given the points, but I would say that you must walk at least 250 to 300 steps every hour if it's possible, which takes around 2 to 3 minutes. And by the end of the day, you should walk around 5,000 steps, if at all you don't do any exercise. That doesn't mean I'm trying to say that you don't do any aerobic exercises. Go for walks in gardens where you get fresh air. At the same time, you can improve the quality of the bone. And you should involve in some physical activity. Don't be a couch potato. Don't be a sedentary worker. In your work also, every hour, you make sure that you walk for at least 3 minutes and complete your 250 to 300 steps. At the end of the day, if you do 5,000 steps, I think you will improve the quality of the bone And if at all you have any kind of problem, you must seek the attention. Secondly, about vitamin D, if below 30 they call it insufficiency or less vitamin D, I would go to the level of maintaining it to 50. So those who have done their vitamin D, then you should see that some of the general practitioners also do not understand. They try to keep it to 30. I would prefer keep it to 50. And by your sunlight, I do not think you get iota of any little bit of also vitamin D. So if your vitamin D is not proper, you have to take supplement. And calcium supplement may be necessary, but don't overuse it. You use it judiciously.
Thank you, Dr. Asavari. Is it possible to get Dr. Yogesh Pithwa in any way? Means we're just not able to get him into the discussion. Even if he can answer this last question, maybe it will help us to wrap it up. His
Sir, I
connection is
tried
poor.
coordinating with him, but his connection is unfortunately very poor. So he's not even able to join from audio.
Okay, no
So
issues.
I am afraid we won't be able to have him. But we do have 2 patient questions. So if you can take those up, I will just
Yeah,
show
it's in
them
the
on
chat
the
box.
screen.
Yeah.
Yes, sir. Patient question.
So do you
First is this
prefer
one.
treating teriparatide to the patient before going to surgery, just to maintain the bone quality before surgery? This is a question by Pratik Bandare. I think, Arjun, you can answer this question. Do you prefer treating the patient? Can you repeat the question, Asavari? 1 second, I'll just go
Yes,
off.
sir.
Yeah, do you prefer treating teriparatide using teriparatide for the patients before going for surgeries, just to maintain the quality before surgery? Arjun,
Yes,
because you do a
so
lot of
that's a good
spine
question.
surgery, so would you like to answer this question?
Thank you for the question, sir. I'm actually fortunate to work with your better half, for the cases. So,
Yeah.
so now basically it's a great question, and yes, there is an indication to use teriparatide perioperatively, because if you start this so if you see a patient who is osteoporotic and is going to require, say, spine surgery, and is going to require, say, fusion, for a listhesis or for osteoporotic compression, it is a good idea to start the treatment prior, because it definitely does help the bonding, and the less it decreases the risk of any implant failures, because you don't want, finally, if you're doing a surgery and you're using instrumentation, whether it is in the spine or anywhere else, or in the hip, you don't want there to be any implant failures, because eventually the metal and the bone interface has to sort of bond, and there should not be a pull out of the implant. So it is, if you're planning an elective surgery, yes, you can sort of start it and then 3 months later plan, of course looking at all the other metabolic parameters and the indications, contraindications, etc. But it is a practice which we often use, and we do
Yeah, the
continue
same. Sorry, the same doctor, same person, Pratik Bandare, asked a question that what are we doing to educate patients about osteoporosis? Because there's a lot of literature and education on other chronic diseases like diabetes and other lifestyle related diseases, but there doesn't seem to be much educational material related to osteoporosis. So I think this seminar was in this direction, and I think at the end, those who have heard this seminar and heard the speakers would have definitely felt more enlightened at the end of this to understand the issues of male osteoporosis, which are equally important and equally common. Basically, I would say in a very simple way that whenever you in your clinical practice you see many patients who are males and who have some unexplained backache, or who have backache which you really don't cannot put a finger on and say what is the cause of the backache, that is the time when you should think that probably these are osteoporotic guys and they require something. Even very often they just come with muscle pain, they don't often even come with bone pain. So it is these patients which we should be sort of aware of. And I think for the patients, to make them aware, they should be understanding that any backache which is like we don't seem to be having a clear reason for the back problem, we should consider male osteoporosis as a cause of the back problem, and then search for the primary and secondary causes. Is that, I think, answer? If anybody wants to elaborate, they can please go ahead and speak. No? Anybody? So I think we've almost reached end of time. It is, I think, now 7:55. So I think we are well in time, and I thank all the speakers for sticking to the point, giving pertinent answers to the questions, and making sure that the webinar has been informative. And at the same time, we've not gone overtime or overboard. I thank Zydus and sponsors and Voice of Healthcare for conducting this webinar on this very important topic. And I thank you for giving me the opportunity to moderate this session. It was indeed a pleasure to interact with all of you. Dr. Dilip Shah, my old friend. Arjun also is well known to me. Dr. Syed, nice knowing you. Dr. Swapnil, thanks a lot. Thanks for everything. I think I hand over to Dr. Savary to wrap up the session.
Thank you, Dr. Jokhi. That was so expertly led. With that, we come to the end of this very interesting session with Zydus, as well as all the eminent doctors we have today. I thank all the eminent participants for taking out their valuable time, for sharing with us all the knowledge and insights into the topic of male osteoporosis. And I also thank all the viewers for staying with us till the very end. For more such updates and information and insights on clinical topics, please keep on watching. With that, we sign off. Thank you so much.